Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. Thanks so much for being here for this second segment. I have the wonderful Dr. Jeremy Silk from Salinas and the Monterey Peninsula. Dr. Silk, thank you so very much for being here.
Thank you for having me, Dr. Morwood.
Jeremy, or Dr. Silk, of course, I want everybody to know we're friends, and I have a lot of respect for you. We're going to talk about tissue grafts, but before we get to that, let's talk about you. You
Sure.
are a board-certified plastic surgeon.
Mm-hmm.
Now, again, remind us what board certification means in plastic
Certainly.
surgery.
So board certification means that you've been through an approved training program, and then you've gone on and achieved, if you've passed your boards, that means you've gone through a kind of a more rigorous program, and you've been recognized by other established plastic surgeons as being essentially a legitimate plastic surgeon, although certainly there are plenty who are not board certified, but that's kind of a stamp of approval of a general stamp of approval from the other plastic surgeons.
So, Dr. Silk, so after high school, and then after college, and then after medical school, so 4 years of college, 4 years of medical school, and then tell me about that afterwards. What kind of training did you have?
After that, I did an additional 5 years of general surgery residency, and actually I'm double board certified because I'm board certified in that as well. So that was 5 years of additional training in surgery, and then 2 years of subspecialty training in plastic surgery to follow that. So 7 years of residency following 4 years of med school and 4 years of college.
Okay, so high school, and then college, and then medical school, and then general surgery residency.
Yes, sir.
And then plastic surgery fellowship and residency.
Mm-hmm.
And then you were in private practice for a while, and then you got your boards.
Yes, you have to be in practice for a little while before the boards happen. That's just part of the process. So
well, excellent.
That's a normal part. But,
Dr. Silk, welcome to the club.
Thank you very much.
So, Dr. Silk, let's teach our audience, whether they're listening or viewing, about grafts.
Certainly.
Now, there's all kinds of different grafts. Let's start to talk about skin grafts. I think most of the audience has at least heard about a skin graft. Now, can you describe that for us?
Absolutely. It's one of the most common reconstructive procedures that's done. It's sort of what we think of as the bottom of the reconstructive ladder, meaning it's one of the most common the first thing we go to in terms of a tissue graft. It's the simplest thing. So that would be where we take skin from one part of the body, and we have a little machine that shaves off the outer layer of skin. And I tell my patients that you can think of it like a cheese slicer, unfortunately, in that it takes a perfectly thin, level piece of skin, and where we take it from, it'll grow back. And we take it and we put it on whatever the defect is, and sometimes those are very small things, and sometimes those are really large wounds. It can be very big areas. So that's kind of where the beginning of tissue grafts start, the most simple one. And you place it down there, and it'll grow in, and that way they're able to heal much faster than they would have otherwise.
So, for example, in plastic surgery, we'll sometimes care for a person who has gotten burned,
Sure.
right? Now, not everyone who gets burned needs grafting or even needs surgery, of course. So why is it that sometimes people who are burned need a skin graft?
The reason for a skin graft would be that you've actually burned through all the layers of the skin and you're down into the deeper tissues. And from there, if you just have a blister, sort of a scalding burn or something like that, or really any scalding injury, anything that causes a blister but there's still a bottom layer of skin intact, then it will heal. And that's why the graft, where we take the graft from, will heal, because we don't take the full thickness of the skin. We take a partial thickness, usually. There's some exceptions, but generally for what we're talking about, you take a partial thickness, and it will heal there because there's still a deep layer of skin left, and that superficial layer that you take and place on will grow in like native skin as well. So you really want to use a skin graft when you have an area where all the skin has been lost.
I see. And you referred to a special instrument. I think you're talking about something called a dermatome.
Yes, sir.
Right? That's how we take a split thickness skin graft. Now, isn't there something called a full thickness skin graft?
Certainly. There's, in certain instances, you want to take the full thickness of the skin to cover over something, and that would normally be something that's a little bit where you want the skin to be a little softer, maybe where the scar matters a little more, because where we take those thinner skin grafts, a lot of times we'll even mesh them, which means to put little holes in it so that it expands like this. And so when we take a full thickness skin graft, we actually take the full thickness of the skin and remove it. We sew it up where we take it from, and then we place it back down. And that, again, would be more for either a cosmetic area in the face or something like that, because it'll scar a little better, or an area where things have to move. So there's certain indications where we might take a full thickness skin graft.
So for example, oftentimes if I do a skin cancer reconstruction, if the dermatologist or Mohs chemosurgeon sends over a patient who's had a skin cancer removed, I'll oftentimes do a full thickness skin graft as opposed to a split thickness skin graft. Sometimes the cosmetic result is better.
Certainly on the face, and things also, split thickness grafts will tend to contract more, they'll scar worse as time goes on. So if it's, again, more of a cosmetically sensitive area, like the face, something where you're worried more about it, then we think about the full thickness grafts. And so there's a little bit of decision making to make as the doctor.
Well, Dr. Silk, there are other types of tissue grafts we do, right? Could you talk about other types of grafts besides the skin?
Certainly. You know, if you move through the levels of the tissue, you have the skin, and then you have this fat, subcutaneous fat, or just the fat beneath, which is the yellow stuff if you've ever had a really deep cut. Beneath that, you have the tendons and muscles, and then the bone. And it's actually possible to transfer any of these. Probably the most common used materials would be fat, which is kind of an up-and-coming thing in plastic surgery. There are plastic surgery experiences fads like anything else, and I don't know if fad is quite the right word, but it explains what I'm thinking about in terms of something that's kind of a hot topic right now, and the use of fat for facial rejuvenation, cosmetic uses to fill out wrinkles as a permanent solution for some wrinkles has really been around for 10, 20 years. Lately, the idea of using fat to reconstruct breasts and even maybe someday down the road in this country, using it for breast augmentation is out there. Certainly, it's even used for gluteal augmentation. So the use of cosmetic use of fat is a newer thing relatively to plastic surgery, and we're refining techniques, but fat would probably be the first thing that would jump to mind. And then additional transfers, really you can almost replace just about anything within reason, I guess, but we're actually able to replace muscles. You can take bone from one leg for someone who's lost a big piece of bone, say that someone's been in a terrible automobile accident and they lost a segment of their bone. It's possible to take skin and muscle and fat and bone from the other leg and replace all of those things by moving it. So those are called free grafts for public education purposes. And when you start to talk about these tissue grafts, it's a little more complicated surgery.
Well, Dr. Silk, it sounds like we want the public to know that when we do grafts, whether it's a bone graft or cartilage graft or skin graft or fat graft, we're taking tissue from one part of a person's body and we're essentially transplanting it to another part of the body. And of course, most of the audience is familiar with the concept of, say, a heart transplant or liver transplant, but those people need to stay on special immunosuppressive drugs and agents, medicines, correct? Now, if a person undergoes a skin graft, do they have to stay on special medicines, immunosuppressive medicines?
I think that actually leads to something interesting that I was going to talk about, but you know, when it's your own tissue, you don't have an immune response to it. Your body doesn't reject your own tissue. There's a chance whenever you move tissue around that it may not survive, but that's very different. When you put someone else's liver in your body, unless it's an identical twin, your body will react to that and eventually shut it down and fight against it. But if it's a skin graft or even your own tissue, muscle, bone, things like that from your own body, your body will not reject those because it's you. However, there's a new arena, and this would be experimental things, but in plastic surgery we have kind of something comparable to that with the face transplantation, which is a fascinating experimental, new thing that's out there. But I think that's a fascinating new use, and those people do take someone else's and have to be on those drugs.
Well, as well as hand transplantation.
That's correct.
Yeah, for
absolutely.
people who have typically both hands amputated in an industrial accident or in a bad motorcycle accident, or et cetera. Now some certain centers in the world, there's only a few of them, are doing hand transplantations.
Highly experimental, but fascinating, and maybe someday in the future, that'll be something that's perfected that we're all doing.
Well, so those people actually do need to take immunosuppressive agents, correct?
Certainly. Yeah, and I didn't mean to confuse the issue. For most people that need a skin graft or would have to have a free muscle graft, what we call a free flap type surgery, having your own fat, most people don't need this. That's a very subspecialized group. I didn't mean to confuse the issue, but I think it's interesting that that's out there.
Well, Dr. Silk, I do a lot of breast reconstruction, and I know you enjoy that area as well, and you're good at it. I heard about a real case, true life case, where a woman had a tummy tuck flap for breast reconstruction. She had what's called the tram flap on one side. Years later, she got breast cancer in the other breast and needed a mastectomy. Well, we can only do the tram flap or tummy tuck flap one time, but she happened to have a twin sister who had never had a tummy tuck or a tram flap or breast cancer, and her twin sister actually donated her tummy tissue, and they were immunologically the same. Her sister donated her abdominal tissue to her sister with the breast cancer for her second breast.
That's a fascinating case study, and that gets to the difference in who needs those drugs and who doesn't. If you're an identically genetical twin to your twin, then you don't have to. Then your body will recognize it as though it were you. Fascinating.
Dr. Silk, now what about for cosmetic, let's say nose jobs? The medical term, the term we use is rhinoplasty. Won't we oftentimes do cartilage grafts for nose jobs or rhinoplasty?
Absolutely, absolutely. Cartilage is used in a variety of ways, but it's a great substitute for the nose, where most of the soft tissues of the nose are held up by your own cartilage. So we try to replace like tissue with like tissue. Just as if you lost a big chunk of muscle, we would replace that with a muscle from somewhere else in the body, or at least consider that. When we take rhinoplasty grafts, we can take them from the cartilage inside your nose, in the septum, down deep inside. You can take it from your ear, and you can even take it from the ribs. And that cartilage will grow in and act as a stabilizer, and it's much softer than if we took a bone or something like that, because your nose really should be soft. So it's a commonly used materials, and they work really well.
So that's an opportunity. There's an incidence, or that's an example of where we would use a reconstructive technique for a cosmetic surgery operation.
Certainly.
And I don't mind telling the audience is that in our field, especially for board-certified plastic surgeons, cosmetic surgery and reconstructive surgery, sometimes there's a lot of gray, right? They intermesh with each other, and we'll borrow a cosmetic technique for a reconstructive case, we'll borrow a reconstructive technique for a cosmetic case. Isn't that true?
Absolutely. I agree 100%. I mean, certainly you see folks that have had big-time large skin cancers on their face removed, surgeries where it's left a deformity. And when you're reconstructing that, you know, that's not the same as having a facelift, maybe in terms of the thinking behind it, but certainly their hopes are that it looks as good, you know, as anything. And sometimes when we're doing, you all know with breast reconstruction, every once in a while, breast reconstruction, you know, will actually turn out better cosmetically than things started. So it's a very gray area, and I mean, the truth is, patients want to look good no matter what surgery they're having, and they ought to.
Right. Well, Dr. Silk, what do you tell patients in your office when they come in and they say, you know, I want the plastic surgeon to do my operation because I don't want any scars?
I always tell them, it's a great question, and I'm sure that's one that you've had many times. No matter what we do, anytime you make a cut in the skin, no matter how minute, there'll always be a scar. The difference is that I tell them that I can give them a scar that won't be disfiguring, and with any luck, in most cases, a few years down the road, depending on what you're doing, for something small, the scars will be imperceptible. And I think that's what most people want intuitively. But I always have to tell them that there will be a scar, and that's a good patient education point, is that no matter what you do, sometimes it leaves some sort of small scar. But the good news is, for most of these things that we do, including especially the cosmetic things, those scars generally will be imperceptible and aren't a problem at all.
Dr. Silk, I have this phrase I use in my office. It's called permanent visible scar. PVS, permanent visible scar, I think just to teach patients that even as plastic surgeons, even though we try very hard and we try to disguise scars and make them as minimal as possible, as you said, every time an incision is made, it leaves a scar. Now, Dr. Silk, can we take a couple of minutes to teach our audience the difference between a graft that we've talked about and a flap? Because there's different types of flaps as we move tissue around in the body. There's a regional flap, there's local flaps, and there's microsurgical flaps. So can we teach our audience the difference between a graft and a flap?
Certainly, certainly. Yeah, I touched on this before, but probably was moving a little fast. So the difference between a graft is that when you take something, a skin graft or fat graft is where something's removed from the body, completely detached, and then placed back on the body. The difference between a flap and a graft is that a flap either remains attached or gets reattached. So a skin graft is pushed down against the skin, we'll sew it down. fat is injected in, but it's not secured back down exactly in the way that a flap would be. When we take a flap, that means a piece of tissue such as a muscle, sometimes a muscle and skin, and the reconstructive for the breast, we take the skin and muscle from the stomach and we can transfer it up into the chest, and you can either leave it attached or you can remove it and hook it back into the blood vessels up there, and I know that's something that you do. And that is the difference between a regular flap and a free flap. So a free flap is one that is removed, and we're now talking about much bigger surgeries. We talk about the muscle flaps and things like that, and then when they become the free flaps, it adds another level of complexity, because in that instance, rather than leaving it attached so that it's still alive, we remove it and then reattach it under the microscope, reattach blood vessels, arteries and veins. And so no matter what you do when you're moving something very large like that, it has to have a blood supply, otherwise it will die. And so you can maintain blood supply by leaving it attached, or you can maintain blood supply by repairing those blood vessels, and we usually hook them into somewhere else in the body. And so that's sort of, if skin grafts are at the bottom of the ladder in terms of complexity, that would be at the top.
So free flap is sort of almost a slang term that we use amongst ourselves. Free flap is really a shortened form of what we call a free tissue transfer or free tissue flap. And that involves microsurgery, correct?
Yes, sir, yep.
So what is it that we're doing? Let's teach our audience exactly what we're doing when we use the microscope and we move tissue around.
Certainly. So the key to making something successful, something that's going to live, if you have something, a small thing or a thin thing such as a skin graft, even if it's large, it's very thin. When you're talking about moving a muscle around to fill a very large hole from an accident or a cancer resection or perhaps a mastectomy after breast cancer, you need a large piece of tissue. And a lot of times that piece of tissue will include muscle and skin and fat, complex things. Those are maintained alive by having a large artery and vein. You need to have that in there. And so like I said, you can leave it attached, or in a free flap, they're actually divided. We put little tiny microscopic clamps on them, remove it off the body completely, place it where it needs to go, fill whatever the defect is, and then take those and find blood vessels to hook them up to. And I use this example because it's usually breast reconstruction, although the leg is another common area. And you bring in a microscope that's about 10 feet tall, and the surgeon and the assistant both actually do it under a microscope, and it's done with tools that usually only jewelers would use, and the sutures are the size of a human hair, and we sew things up that way, and you can plug it back in and it will live.
Well, it's fascinating, and it's fun and rewarding, isn't
it?
And it's a powerful tool that we use in plastic and reconstructive surgery.
It is.
Dr. Silk, in case our audience has questions about tissue grafts or any other area of plastic and reconstructive surgery, can we give out your name and number again?
Certainly. Jeremy Silk, Salinas Valley Plastic Surgery, 758-2746 in the 831 area code, or salinasplasticsurgery.com.
Can we give out that number again?
Sure. 831-758-2746.
Dr. Jeremy Silk, thanks so much for being on the program. I hope you come again. Nice to have you here.
Morwood.
And once again, this is Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and we're going to take a very brief pause for a good cause. I hope you stay with us.